And I'm very happy about the number of people who took photos of that beautiful quote. So thank you. Walter Greenleaf is a behavioral neuroscientist and medical technology researcher here at Stanford. He's also a scientific advisor, board member, and executive at several of the very hot VR companies, for example, Therapeutics and MindMaze that we've been reading about a lot. Walter, welcome.
Okay. I'm excited to be here. While we get my slides spun up, I'll tell you why I'm excited to be here. For me, it's been a personal journey starting almost 30 years ago within sightline of this building. I started as a research scientist, as a graduate student in neuroscience, and started down my journey to look at how virtual reality and augmented reality technology could be applied to healthcare. So it's very exciting, as you can imagine, to see the technology finally be affordable, approachable, and being applied to some of the emerging and critical problems in healthcare. So let's see. Can we get the slides on the monitor here also? That would be helpful. Excellent, thank you. I talked earlier with Lisa about the fact that my talk is usually an hour long and we only have 30 minutes. She suggested I skip every third word, said it's a very intelligent audience and you'll be able to keep up with it. And John, of course, has warmed up the audience. I do a lot of work with not-for-profit groups, but I should also mention that I also work with a number of the emerging startups in the space I'm talking about, so I do have some confirmation bias built into my approach to this issue. I think one of the biggest problems that we should as a society face is the healthcare crisis engendered by the aging populations. All we have to do is the math. It's not a matter of theory, it's a matter of arithmetic. If we look at the aging population we have, how many people right now will have serious mobility or neurodegenerative disease in their 80s or 90s, when the boomers get up there, is at risk of bankrupting our society unless we come up with answers. And of course, it won't be surprising to people in this room, some of the best answers will come from technology as appropriately applied. And wearable technology is a big part of that. As you know, there's a digital health revolution going on with everything from wearable sensors to making the person the center of activity, leveraging social and qualitative and quantitative measurements. And as you know, every medical device has been reinvented and moved from an analog world to a digital world. This allows us to do amazing things with data sets and pushing and pulling interventions to our users and harvesting that data, changing it to provide dashboards and population statistics to research scientists. A big part of that medical healthcare revolution is what's going on right now as the tech companies move into healthcare. I view it as the continents colliding, that as Apple and Google and Samsung and Amazon and the major corporations move into healthcare, it's really going to shift things dramatically. And a big part of that is how the emerging technology of AR and VR are part of that. How many of you have had a chance to use a virtual reality system? If I'd asked that question 2 years ago, maybe 10 people in the room would have said that. It's really becoming something that we're much more familiar with. The term has been socialized and people are a lot more comfortable about it. I think that although entertainment and gaming are driving the initial adoption, that as VR and AR technology and AI technology with it move to the enterprise, medicine will be one of the deepest verticals. And I'll give examples of why. So every major tech company has billion-dollar poker chips put onto the spot for VR and AR technology, and they're all eager to see it move to the enterprise. And again, medicine will be one of the biggest verticals. The analysts project that within 6 years we'll have more than 70 million users of AR and VR systems. Within 3 years, 30 million users. So there's a concern that there's just not enough people using the technology, but we can leverage smartphone technology and tablet technology and use that technology as part of our interventions and improved assessments. And again, the analyst whose job is to look at this very carefully to make predictive modeling for investments are projecting within 6 years it will be a $35 billion market. And I'll give you some examples of why that is, and I'll get very specific in the time that I have. And by the way, when I say VR technology, I really mean the whole spectrum of immersive technology. Sometimes we overlay the world with what people sometimes call mixed reality or augmented reality. But sometimes we step into a room that is sensitive to our movements and can connect us with other people in a room-based AR or VR system. So again, I started here back in 1984 getting into this. It's been an exciting journey. Back then, the computers we used were refrigerator-sized and cost $500,000, and the headsets were so heavy we had to counterbalance them with a brick. But we were able to do some basic research. And I've had a number of colleagues over the last 3 decades looking at the medical applications of VR. This is an important point because many people, especially some of the people who are just getting into the field now, think that we don't have a roadmap of how to apply the technology. But if you go to PubMed, look into it, there's 3 decades worth of basic research showing what the proper pathways are. Now we need to redo those studies because they were limited in size and based on old technology. But we have a general idea of what pathways to go down to make a big difference. Stroke rehabilitation, for example, has been studied extensively and its value using AR and VR technology to facilitate home rehab. But there are many markets where the technology has been researched and applied, and we know that there's value. Right now I see 160 or more emerging startups that are funded and at least 20 different clinical sectors. Back in 2008, I tried seeing if we could migrate some of the VR technology at the time to be used to help with treating post-traumatic stress. I went over to Sichuan, China after the earthquake, seeing if we could help with the large numbers of mostly school children who'd had a bad experience because of the earthquake and were traumatized by it. It was not scalable. We could not do it. But as an example of how much things have changed, after the 2017 earthquake in Mexico City, we were the very next day able to send in a SWAT team of people using smartphone-based AR technology and VR technology to help address the trauma that occurred after that earthquake. So the technology is available now and can be scaled. Again, there's many companies working in this area. There's also significant investments going on. There's several companies that have received significant investment at the Series A stage. And there's even one public company that has set up a division to focus on AR and VR technology. There's also Unicorn MindMaze, which has raised several hundred million at a multi-billion-dollar valuation in this space. So I think the reason we're lurching forward now is the technology is finally affordable. The biggest constraint before was that it was very unwieldy and very expensive. So I think this is the major point that I'd like to make right now, is that it's the full stack of medical care that's being affected by this emerging technology. It's not just surgical training, it's not just home rehabilitation. It's really the whole sequence of medical care, starting with prevention wellness, doing more objective assessments of cognitive function and behavior and mood, motivating people to adhere to an intervention, and reaching out to underserved populations. I'll give some specific examples. Carla Pugh, I think, was here. She's doing research right now on how we're using simulations to improve clinical skill training and surgical skill training. But it's also the interpersonal skill training that can be done, team training using a simulation. We can teach people how to specifically use equipment and tools, and we can simulate large scale rehearsals to a disaster, for example. And again, we can also use VR to help facilitate empathy by having you see the experience of someone else from their point of view. So we've had training situations in VR for decades, but they've been very expensive and required people to travel to a dedicated simulation center. But now we have systems that can be used in a multi-user, telemedicine, remote training manner to teach people how to use a specific medical device or how to do a specific technique. It allows us to do just-in-time rehearsal or training of a procedure too. The medical device companies are getting into the act by designing their systems to be used and for people to practice how to use them right before they might do a procedure. And we can do procedure planning by taking medical image data, rehearsing a complex operation in advance. We also have virtual patients and virtual cadavers, where right down to the fine degree anatomical model, all the way up to the behavior of the cadaver can be emulated. And of course, we can have teams rehearse how to handle a specific procedure. Here's just a quick video clip of how one group is using VR to help train new residents how to work inside an emergency department and prepare for different procedures. I think there's some audio that should be going with this. Thank you.
Choose a location for the chest.
And actually, the graphics on this particular example are several years old. We can do much better now. So at the Children's Hospital of LA Emergency Department, they've put a lot of effort into developing a system to train incoming residents on pediatric resuscitation procedures. They took staff members, captured their motion, built very realistic scenarios, and have been using it to train them for this high-stakes, low-frequency procedure. And one of the conclusions that they published is that the VR training is best affected towards the younger, less experienced trainees. The more experienced trainees don't get as much benefit from it. But they've actually now put it in VR as part of the required curriculum for the interns prior to even they go into the emergency department. And they're now rolling this out to many other research and training hospitals as part of the training curriculum. There's whole aspects of disaster preparation that where towns can integrate the police force, the emergency department, the fire department to rehearse how to respond to a disaster situation. We also have a number of groups that are developing VR systems so that you can see the patient experience from the patient's point of view, and I think this is an important part of our training process. Here at Stanford, David Axelrod has developed a system that he's using to train both interns and residents here, but also people who've come from other countries to get trained using the simulation that he has. And one of the things I like about what David is doing is that it's also allowing him to do a better job of informing his patients and their families about the procedure that he does. For a complex procedure that involves repairing a heart, being able to see it in 3 dimensions really helps them understand exactly what the procedure is, much better than looking at a sheet of paper describing and providing informed consent. So we also can do preoperative planning and image-guided surgery much better using VR and AR systems. And one of the areas I'm particularly excited about is better diagnostic assessments. We can do objective assessments of behavior and challenges in a more realistic manner using VR systems. So again, we can create a very realistic simulated environment, have people go about a task, and we can measure very precisely their gaze, the sequencing of their movements, what they're doing, how they're interacting with other people, much better than asking someone, how are you doing today? How are you feeling? How did you feel last week? We can do a much more complex analysis of cognitive assessment and changes over time, how people are responding to treatment. Almost everybody in the room mentioned that they tried a virtual reality environment. How many of you have tried the demo where they have you walk a plank? A lot of people. That's sort of a very common demo. The purpose that those demos of having you go up in an elevator and walk out on a plank and maybe rescue a kitten is not to traumatize you, although I've seen some people who've been traumatized by these demos, is to show the principle that we can evoke a cognitive state. And if we can evoke a cognitive state, in this case maybe a fear of heights, we can teach people the skills to manage the cognitive state. So when it comes to anxiety, when it comes to depression, post-traumatic stress, reaction to painful stimulus, we can use the fact that we can evoke a cognitive state combined with cognitive behavioral therapy and other interventions to help people address those conditions. And again, VR has allowed us to come up with new tools for doing cognitive evaluation. At the Virtual Human Interaction Lab here at Stanford, we've come up with some standardized virtual environments to evoke different emotions, to evoke feelings of joy, of sadness, of disgust, of anger. And these can be used in both basic research, and they're being used right now as part of Lee Williams' project to come up with more precision diagnosis of depression, combined with medical image and other assessments to come up with a standardized environment for neurocognitive evaluation. To talk a little bit more about medical wearables, one of the things we're doing using head-mounted displays is capturing facial expressions. By doing that, we can abstract that information to come up with an emotional score and combine that with the stimulus that we can do in a reproducible manner in a virtual reality environment. We have systems using AR technology to do an improved assessment of cognitive impairment, doing a better diagnosis of neurodegenerative disease and mild cognitive impairment. In this case, the company Altoida is using a tablet so that they can reach, or a smartphone, so they can reach out into primary care and using the sensors embedded in that smartphone to capture movement and speed of decision making. And they've been able to come up with a test, 10-minute test, that has a 94% accuracy with standard measures of cognitive impairment. Again, this allows us to do a very sophisticated assessment using the sensors in the tablets and smartphones at the primary care level. Let's see. So we're currently using virtual environments clinically. We have a clinic here at the Department of Psychiatry at Stanford, but VR is being used extensively right now for stroke and traumatic brain injury recovery, for facilitating physical and occupational therapy, helping addressing both acute and chronic pain. And there's been a lot of progress in some very difficult aspects of mental health, helping with depression, helping with autism, helping with attention deficit disorder, helping with anxiety disorders. Phobias, obsessive compulsive disorder, anger management, eating disorders, and psychosis. And this is really important because one of the most problematic areas of our healthcare system right now is the stigma and the long delays in mental health care. If we can use technology to help us reach people to do a better assessment of their state, maybe put the people that need to be at the front of the line at the front of the line, this is incredibly important because the average wait list now, when somebody finally makes that phone call regarding an addiction or a panic disorder, is sometimes 3 or 4 months. So we need a better way of reaching people, supporting them in the meantime, or putting the right people at the front of the line. So we can motivate people to adhere to programs using VR. We have some techniques to do that. And again, VR allows us to reach into underserved populations in a telemedicine manner. We're using AI combined with sensor technology to do a better job of training clinicians on how to work with patients. And as you probably are aware of, the AI systems that we're using behind the avatar technology are getting much more sophisticated. Here's just a quick clip. I don't think we're quite on the other side of the uncanny valley, but we're getting there.
Made using Orban's artificial intelligence technology. As Nikhil's personal AI, I enable Nikhil to spend more time with his wife and 3 kids, enjoy a nice hike, or go off-roading. Ni hao, washe ni kao.
Nikhil doesn't speak Chinese, but his avatar does. And he doesn't dance, he doesn't sing very well, but his avatar can dance and sing. So it's really amazing if we capture people's facial expressions and voice tones, we can map them to a pretty realistic looking avatar. Now, this worries me a bit because, well, I'd love it for medical purposes to be able to have a clinician's avatar do post-discharge follow-up with a patient instead of giving them a stack of papers. But I also know that so many of our systems are being hacked. I'm really worried that my avatar will be put into virtual worlds and used in a way that's not appropriate. So it's powerful technology, but it's also technology we have to be very careful about. But we are using right now technology like this to help physicians practice how to deliver bad news to a family about a terminal illness, for example. Let me give you some specific examples of how VR is being used right now. There's a lot of work, and it has been done over the last 15 years, teaching people to deal with fear of heights, fear of flying, and also dealing with post-traumatic stress. We use VR as part of palliative care and hospice care. There's a lot of groups bringing the technology into memory care and assisted living facilities to help seniors who otherwise might be very isolated and not have a chance to interact with family or friends except through a Skype call or something like that. It allows them to have an experience with family members or friends. We're doing much better assessments using VR environments, including attention deficit disorder. And this one I'm particularly excited about is helping with addictions. We can use VR to teach people situational confidence and refusal skills. So instead of having a coach say, when you're in a party situation and your friends are putting peer pressure on you, what are you going to say? You have to elicit the emotional state. You have to elicit the cravings in order to teach someone to manage the cravings. And we've done a very effective job using VR to do that. We can also use VR to help reduce anticipatory anxiety. Here's a project we did here at the Stanford Children's Hospital. We call it Project Braveheart, where we worked with the children and their families who were scheduled for a scary cardiac procedures. We captured 360 video in advance of what the procedure would be like and what going to the hospital would be like. And we had them take it home in a mobile VR system, get familiar with the layout of the hospital, what was going to happen, so they knew what to anticipate. And probably most exciting was the fact that we were able to green screen in kids who had the procedure before to serve as guides. So here's a very quick video clip of that project called Project Braveheart. Maybe we could turn up the volume a little bit for this one.
Braveheart is an interactive VR experience developed to reduce stress levels in children who will be undergoing a surgical procedure. Patients and their families are guided through a 360-degree video tour of the hospital by a virtual companion. The gender-specific tour guide provides a friendly, approachable, and relaxing tour of the facility and introductions to doctors and key hospital staff. Along the hospital tour, patients visit the key rooms they'll encounter on the day of their procedure to help make the unknown more familiar. Children learn about parts of the procedure and can even practice mindfulness.
We
and
snuck in
relaxation
some
exercises.
relaxation training games.
The intuitive software design allows the user to navigate through scenes and applications, learning the hospital layout, all within Braveheart at their own pace, creating a first-of-its-kind, interactive and immersive video environment.
And we
When
get a lot of
Braveheart is
data
finished,
afterwards, so we
anonymous
understand what
usage analytics are stored
what
and
people are most
available
worried
by
about in
scene,
terms of the whole
time,
procedure.
and engagement for analysis by doctors and researchers.
It's just one example, but I find it an exciting example because 360 video is really inexpensive to capture and create. So it's a way we can take almost any procedure and help people get more familiar with it in advance. VR has been used extensively for both acute and chronic pain distraction and teaching people, again, the cognitive skills they need to have to manage pain. We're collecting a lot of data about people's utilization and using virtual environments as a way of challenging behavior. And here's a key point. These VR and AR systems are not used in isolation. They're part of a digital health platform used in combination with pharmaceuticals, for example, or being used in combination with a therapeutic device. This is a transcutaneous device that stimulates the vagus nerve through the auricular branch. And it's a hearing aid sized device, and they're bringing it out to help address vagal tone through this procedure. But the way the company is thinking about it is not, here's a device we're developing in isolation. They're viewing it as part of a platform using other wearable sensors and AR and VR technology. So again, not just to have the device to trigger a change in the individual, but have it be part of a platform that learns the most effective way for the user to use it, puts it into a system where the clinicians can interact with the patient through a dashboard and adjust it dynamically. So VR and AR are a big part of that process by having the ability to provide a mindfulness training environment, for example, to accompany the device. There's, of course, a whole neuroscience behind the theory about why this works. I'll be very brief. One of the things that we can do is leverage our mirror neuron systems by age progressing an avatar of the individual. It's amazingly motivating to see yourself aged 10 or 15 or 20 years and see the results of your behavior affecting your avatar. And this doesn't have to just be on an immersive VR system, it can be on your cell phone. Perhaps you've decided you want to reduce your drinking. when you walk into a bar, your future self can call you up on your cell phone and say, what are you doing? I thought we talked about this. So we've done some studies here at Stanford where we've leveraged this technique. We gave some Stanford undergraduates, and believe me, if you're a Stanford undergraduate and you see yourself age just 10 or 15 years, it can be very motivating to change your behavior. But we gave them some cash, and we gave them a choice whether to keep it or to invest it in a retirement fund. And believe it or not, those undergraduates who got to know their future self elected to save for retirement, some of the money. The other advantage of VR systems is that we can build narratives. And a big point of how to change behavior is to be able to tell a story, to, as John pointed out earlier, maybe invest some humor into it too. And we can couple our medical devices, our wearables, our other interventions with a whole story, a whole experience by leveraging AR and VR technology. And I think that's very profound. Because that's what motivates people. And we do have to motivate people to adhere to a process. So just very briefly, what is the downside? What are the constraints of this technology? Well, part of it is that, which platform do you use? If I go to a clinic or a hospital and say, here's a particular product you should consider, they'll say, well, we're not sure we want to buy that particular platform, the Oculus platform, the HTC platform, the Samsung platform, because we don't know who's going to win, which company is going to be the dominant player. So much like the VHS issue held back people from making a choice between VHS and Betamax before, we have that problem right now in terms of who's going to be the dominant player. Also, even though there has been some early research, it's just not enough. We need to do larger studies to validate the approaches. And also VR is perceived as a gaming platform, and that's held back a lot of people in the medical arena from accepting it. And also we need to understand how VR and AR fit into the workflow of a hospital and to really look at the economics of the intervention. There just hasn't been time to do those studies. So again, to summarize, I'm concerned about the healthcare aging process and what's going on with neurodegenerative disease and how we have to come up with better interventions. Nicely enough, from my viewpoint, many of the things that VR and AR technology afford us specifically address some of the needs and issues involved in addressing the healthcare issues of an aging population. So to summarize, VR AR technology is part of the revolution in digital healthcare. I think it's just going to grow in speed and momentum as it moves to the enterprise, and I'm excited to be part of the process. Thank you very much. Okay.
Would you mind taking questions over lunch?
If we have time, sure.
Oh, one question, thanks.
Are you aware of any applications or experiments using AR, VR with Alzheimer's patients?
Yes.
Since they suffer from delusion at the late stages and also the reality for them changes, I'm wondering if there's a way to maybe reduce their pain or maybe even help the brain recover some of the ability that lost.
It's a very good question asking about how VR and AR has been applied to helping with senior care and specific Alzheimer's and other neurodegenerative diseases. It's been used both to do a better, more sophisticated differential diagnosis to separate Alzheimer's from Lewy body disease or vascular dementia, but also to help people who are in these memory care facilities with reminiscence therapy, or to give them experiences instead of just parking them in front of a television set, to actually be able to have them join a family member at a virtual cafe in Florence, for example. And it's also been used as part of providing more relaxation therapy, mindfulness training, etc. And also to help seniors move, to do a virtual Tai Chi with their family members or friends in one of these interactive rooms that have been developed. So there's actually a lot going on in senior care with VR, and some specifically pointed to addressing neurodegenerative disease.
John, one quick question.
Okay, so I'll try and make it really quick. I'm a huge fan of what you're doing, particularly with physical transfer and empathy. And given how polarized we're becoming globally, not just in this country, have you thought about scaling the empathic virtues of the physical transfer to children systematically throughout school systems? Is that Is there anything happening in that space?
Yes. The good news is there's a lot going on teaching social emotional learning skills at grade school level and earlier using VR. It's a great platform for telling a narrative story, and that's a good way to reach youngsters who are learning how to make friends, how to deal with a bully, how to deal with anger management and other issues. And we've also made a lot of progress helping with autism and Asperger's, helping people recognize facial expressions in other people, learning how to make contact, how to recognize nonverbal communications. So it's an area of fertile growth. And we're also doing a lot to helping with people understand biases in themselves, having them have an experience and understanding the whole range of biases, including implicit biases against minorities and age groups, et cetera. So it's a powerful technology. The overused phrase is that VR is an empathy engine. But beyond that overused phrase is the fact that we can have an experience that teaches us something about what it's like to have another person's experience.
Magnificent work. Thank you.
Thank you.
Thank you very much, Walter.
Yep.